The liver is one of the body's principal organs. In fact, the liver is essential for life due to its role. It acts as a filter for the blood. It is involved in the synthesis of the main plasma proteins. It is the main energetic reservoir. We cannot live without a liver. In Greek mythology, Prometheus stole the god's fire. As a punishment, he was condemned to have his own liver eaten every day by an eagle. In response to an aggression, the liver is an organ that can reconstitute itself thanks to a process called regeneration. An acute inflammation of the liver, or acute hepatitis, can lead to recovery, death in the case of fulminant hepatitis, and in a third more common case, to chronic hepatitis. During the chronic process of cell regeneration, a mechanism called fibrogenesis might occur, leading to liver damage that causes cirrhosis and eventually cancer. Today, 5 major viruses are associated with viral hepatitis: A, B, C, D, and E. 2 of them, HAV and HEV, are associated only with acute hepatitis. 3 of them, HBV, HBV plus HDV, and HCV, in addition to acute hepatitis, can lead to chronic infection. The hepatitis viruses can be transmitted by different routes depending on the virus. Both the hepatitis A virus and the hepatitis E virus, which are resistant viruses in the environment, can be transmitted by hydric contamination or through the fecal-oral route. In contrast, HBV, HCV, and HDV will be transmitted parenterally, such as blood contamination for B, C, and D, and sexual transmission for B and D. A specific HBV transmission of the disease is the mother-to-neonate transmission route. The hepatitis A virus is responsible for acute benign hepatitis in 1.4 million cases per year, which never go to chronicity, and most clinical forms remain asymptomatic. Vaccination is efficient and useful for travellers. The HEV burden is estimated at 20 million individuals per year. It is an acute hepatitis, sometimes severe, especially in pregnant women during the 3rd trimester of pregnancy, leading to fulminant hepatitis and death. A vaccine against HEV has only been approved in China. Globally, approximately 257 million people have a chronic infection due to hepatitis B, mostly in certain areas, Asia, West Pacific countries, Sub-Saharan Africa, and certain specific countries such as Mongolia. There are approximately 800,000 deaths due to HBV per year, every year. The chronicity is linked to the persistence of the viral genome in the liver cells. A therapy by inhibition of viral replication is efficient, but cannot eradicate this persistent viral DNA that may also be integrated in the host genome. Therefore, there is a lasting risk of hepatocellular carcinoma. A very efficient vaccination schedule may eradicate the transmission of B and B plus D. It is part of the WHO hepatitis eradication goal for 2030. HDV is a satellite infection for hepatitis B infected patients in humans. 15 to 20 million people are infected. It's an uneven epidemiological infection rate with prevalence of over 20% in some countries, Central Asia, Africa. It's the most severe form of chronic hepatitis, increasing the rate of development of liver cirrhosis and cancer, and also fulminant hepatitis. There is no efficient therapy. The HBV vaccine protects a person from HDV co- or superinfection. Globally, approximately 71 million people are infected by HCV. This infection is chronic in a huge number of cases, over 50 to 80%. It may represent a high proportion of individuals at risk of liver cancer in some countries, such as Egypt. During the last 30 years, strong progress has been made with an antiviral therapy. Nobel Prize for Harvey Alter, Michael Houghton and Charles Rice. And a high efficient healing rate is now obtained, with viral eradication in nearly 100% of patients treated for 8 to 12 weeks. The main problem is that only 10% of people are treated due to a lack of viral infection screening and access to treatment, cost, availability. It is part of the WHO hepatitis eradication goal for 2030. During the next decade, the goal of the World Health Organization is to help countries eradicate hepatitis C and to control hepatitis B infections. This will become feasible by knowing the latest viral hepatitis therapeutic approaches, providing access to diagnosis and therapeutics to everybody. High-technicity reference laboratories combined with point-of-care screening tools and drug accessibility will help such goals. Limiting the cost by using generics, continuously promoting vaccination programs for the virus when relevant, hepatitis A, B and D. In the next decade, hepatitis could hopefully follow the path of variola.
Hi, everyone.
Good morning. Welcome. Thank you for joining. It's my pleasure to start this new webinar from the Mekong Hepatitis Symposium. Prior to the pandemic, it used to be in Laos, but now we have started in between this digital version. I hope you will enjoy it, and I do hope that we will welcome you next year again in Asia.
So I warmly welcome you here at Les Pensières Conference Center here in Annecy and broadcasting you to Asia. I'm Nicolas steenkeste. I'm very pleased to be part of the scientific committee of this symposium. That is last for the last 10 years, and we are always pleased to be with you, even if it's a digital conference. I would like to thank all our organization partners, Fondation Mérieux, the University of Chiang Mai, the Ministry of Health of Laos, CRCL, Centre d'Infectiologie Christophe Mérieux du Laos, IRD, University Sorbonne Paris Nord, the French Embassy from Thailand, Cambodia and Laos, and CRCL. I would like also to express my strong gratitude to all the speakers and organizations that was keen to join this conference, like the World Health Organization, Fine Diagnostics, EASL, and INRS. So thanks a lot for joining us, and thanks again for all the participants and speakers.
So good morning and good afternoon, everybody. I'm Paul Dény. I'm also from the organizing committee of the Mekong Hepatitis Symposium. And this year, the title is Viral Hepatitis Elimination, Promise and Challenges. And we have two sections, one on a B and one on a C. The B section, which is update on hepatitis B care and prevention, will be chaired by Massimo Colombo. And the second one, which is how we can reach the 2030 HCV eradication goal, will be led by Po-Lin Chan, that I thank you. And I give the word to Po-Lin Chan, which will give our keynote lecture. which is entitled Global and Regional Updates Toward the Elimination of Hepatitis. Thank you very much.
Thank you, Paul. Thank you very much, and good day all. Good morning, good afternoon, good evening, wherever you are. And I thank you for the organizers for supporting this. So I would like to first start that this year, all the strategies for health sector strategies on HIV, hepatitis, and STIs are coming to a close. And the World Health Assembly this year has asked WHO to update the global health strategies for HIV. Sorry, the slides are just jumping along. So I would like to report back that WHO has new progress. Just hold on. To the organizers, I am not clicking, but the presentations are going forward by itself. Apologies for the IT. Is it possible to go back? To go back one more. And this year we have the progress report from WHO, which spells out basically that there is a need to accelerate and renew efforts to reach the 2030 targets. Next slide. I'm sorry, the slides are jumping by themselves. Perhaps the organizers can control the slides.
I'm sorry, there is a little latency, but you are in control of the slide.
Oh, thank you very much. Okay.
Thank you.
So what is very clear is that we have massive gaps in the hepatitis B and C diagnosis and treatment. And in hepatitis B globally today, we have hepatitis B at about 10% of people diagnosed by the end of 2019. And in treatment, even less people are getting it. And in hepatitis C, we only have around 20% that are diagnosed and only 13% globally that have access to treatment. Of course, there are different variations in different regions as well. But what is clear, we know that hepatitis is strongly linked and causes liver cancer. And these cancer deaths are increasing. I would like to remind that at this point that hepatitis B and C chronic infection occurs also in children and adolescents, but we don't have a lot of data. And for example, in hepatitis C chronic infection in children and adolescents, we have an estimated 3.2 million people, children up to 18 years old, that are infected globally. We have to be reminded that children get infected through mother-to-child transmission, through unsafe injections and dental care, and for older children, also through injecting drug use. So this is something to bear in mind, that our response to date are in some ways for getting children and adolescents, and this is something in the next 9 years we'll have to work on. Today, 350 million people live with hepatitis B and C globally. By the time I finish this slide, 3 people would have died any moment by the time I finish this slide. But we know the sequelae of liver cirrhosis and liver cancer, and these deaths to occur. In the Western Pacific region, we have about 1/3 of the global total of people living with hepatitis B and C. 116 million people are living with hepatitis B and C. And hepatitis B and C causes most of liver cancer. all countries are affected by liver cancer, irrespective of income status. From the smallest one, like Guam and Vanuatu, to China, Japan, and Korea. Our hepatitis response in the Western Pacific region are generally better for prevention. We have had decades of prevention, and we have good safe blood, as well as harm reduction in some countries, but testing and treatment lags behind. In the Western Pacific region, leadership and governance is important. National plans have improved over the last several years, and to date, we have 20 countries with national plans. Hepatitis is a sum total of synergies from multiple different programs, and it is important that we understand this so that governance includes multiple different programs. Triple elimination is one of the newest paradigm shifts that we have in the region and also globally. Tonight, there will be a launch of the Orange Book, which is the WHO global guidance on the criteria for elimination for HIV, syphilis, and hepatitis B mother-to-child transmission. And in financing of hepatitis treatment through domestic resources, the Western Pacific region has improved a lot. Compared to 2014, we only had 6 countries, all high income, who are financing hepatitis. Today, most countries are financing hepatitis through domestic or social health insurance. Countries that are in yellow, such as Cambodia, Laos, Papua New Guinea, and Philippines, are gradually working on their systems and health systems development. In the Western Pacific region, we lag behind, like the rest of the world, in treatment and diagnosis as well. So finding those missing millions is incredibly important. We know that in the future, it is important to stem that upcoming liver cancer epidemic, and preventing liver cancer today to impact tomorrow is important. And this is really based on active case finding, testing, linked to care and treatment, because most liver cancer is due to hepatitis, and in Asian settings, hepatitis B. We know that hepatitis elimination is a combination of existing interventions at scale, but we need to finance it towards elimination. We have all the menu of options. We have good drugs. We have drugs that are cheap. We have DAA drugs that are reducing in price, but we need to ensure the health system's response, which is universal health coverage, optimizing integration at primary care, finding the hard to reach and engaging communities, and better data and granular data will help us get towards elimination. We have global sector strategies in the next decade to come for HIV, hepatitis, and STIs. And it will primarily be a paradigm of trying to leverage UHC, primary healthcare, and health systems to impact across all diseases, so that this future, this shared vision of ending epidemics of HIV, hepatitis, and STIs can be achieved. And these, we can get towards the goal. There are some lessons from the COVID-19 pandemic when we are continually learning from it. Global health security is only as strong as our weakest link, and no one is safe until everyone is safe. But we know now that we have to build forwards better. Disease-specific response and UHC and global health security are all reinforcing each other and need to be advanced. We cannot just focus on COVID and forget essential services, and hepatitis is essential services. So we have to work all together to pave that way forward and emerge better from COVID-19 to get to the 2030 goals. I would like to thank you with this at the end, and thank you for your attention.
Good morning, everyone. My name is Massimo Colombo. I'm currently the chairman of the EASL International Liver Foundation, and I'm very grateful to the Merieux Foundation and the Scientific Committee for inviting us to chair this session devoted to the hepatitis B care and prevention. I must say that working in the area of hepatitis prevention is also the mission of the EASL International Liver Foundation. And as a matter of fact, we are partnering with CDC in Atlanta in the program of viral hepatitis elimination in Georgia. Without any further delay, I'm very delighted to introduce the first speaker of the session, Professor Paul Dény. He is a professor of microbiology at the Paris Sorbonne University, and is engaged in a scientific activity in the very prestigious group that was established by Professor Trépo years ago in Lyon and is currently led by Professor Fabienne Zulin. Professor Paul Dény will tell us about viral diagnosis, classical and up-to-date approaches to monitor hepatitis B virus and hepatitis delta virus. The floor is yours.
Thank you very much, Massimo. The physical examination cannot lead you which kind of virus is going to do the liver disease. So the diagnosis is often based on virological approaches. And you really know that there is some direct diagnosis which take the HBs antigen for the surface, for the capsid-related antigens, and for the extracted HBe protein. And you will also find the viral genome as on DNA as usual, but now also as a RNA molecule which can be liberated from the cell, infected cell. The indirect diagnosis will be based on antibodies against the virus, and you know there is antibody anti-HB for hepatitis B, capsid, HBC, surface, HBs, and excreted HBe. And I would like to insist today also on the molecular epidemiology that has made a lot of improvement during the last years, and especially I will speak about nanopore sequencing, introducing nanopore sequencing. So the idea, you know this slide, and those markers are present in acute HBV infections. When the infection is resolved, there is some antibody that appears, total anti-HBC, anti-HBe, anti-HBs. And those will be, if you have anti-HBs only, it's maybe due to vaccination, but if you have anti-HBs plus anti-HBC, it may be related to a past infection. Obviously, the HBs antigen can persist more than 6 months during chronic hepatitis. I won't go too much in this slide, just to say that the HBs that you see on the top of the slide is not a linear curve during natural progression of infection. In fact, it decreased during the time, long by little, and you have to follow that by doing the quantification of the HBs antigen. Another point for the HBs antigen is that it can be modified when it's synthesized in the cells, and there is in fact 3 different molecules that code for the HBs antigens, 3 molecules which are present at the surface of the DAN particle. And so, looking for the DAN particles, you will have some modification of the HBs antigen, and especially for the middle Pre-S2S protein, you will have a specific O-glycosylation, and this O-glycosylation may be in very nice relation with the fact that the antibodies directed against O-glycosylated MHBs are neutralizing, and much more than the IgG that you can see on the figure. And also, it's important to consider that when you dose the HBs that are in relation with this glycan isomer, HBsIZ, that means they have this modification with the O glycan on them, they can correlate quite well with the cccDNA. So there is a marker, a new marker, also these results are very preliminary, but there is a new marker that can be correlated with the cccDNA, and that would be important when you want the viral eradication. So the nanopore sequencing on the next slide will based on a very old strategy to amplify the whole genome from Gunther et al. In 1995. But now we can separate each molecule by adding some linkers, and you can have the sequence on one molecule that's about 3,200 nucleotides on one step, and you may pass along many much as the molecule that are present in the serum of the patient, and you will filter and interpret other data which are very strong data to be analyzed, and so you will have information on the molecules for the whole genome. So that would be important not only to see what is a genotype that is infecting the patient. And for example, in Asia, the most prevalent genotype are genotype C and genotype B, which are present in Asia, which have a small deletion into the C genes. And also you can have the I genotype, which is a recombinant between C, A, and sometimes G. So that's the genotypes that are present in Asia. But you will have also information on mutations, and mutation in each part of the genome. You will know the mutant of the polymerase, the mutant, the escape variants, the mutant on X protein, or eventually the resistance to the capsid adapting modulators. So the next step, and not last, it's the fact that you can also see in some serum of the patients some deleted molecules that may code for new proteins, which by their expression in the infected cell could lead to oxidative stress and complication of the liver. Besides all these strong techniques, there is something which is very important, is that the point of care testing. And the point of care testing will be based on lateral flow, which can detect antigen, HBs, and also what can mix different antigen. For example, you can find the delta and the B together on one step. And you can go with a little van, you can go eventually to the population that are difficult to see. And well, you just change. You don't take ice cream, you take viruses. And with the viruses, because we have too much viruses, you can also add the coronavirus for the moment, and you can go to see exactly what are the infection in your rural populations. So the main goal will be to find the disparition of the HBs antigen, to find the apparition of the antibody, and many tools now are present to help to go this way and to kind of a functional cure without HBs, maybe a complete cure if you can eliminate the cccDNA in the cells, and while the sterilizing would be eliminate the integration. That would be another point. And all these points have to be in relation also to find if there is or not a super infection with Delta. And so please, depending on your country, even if there are low prevalence, maybe there is many people that are infected, and many there is kind of some 15 to 20, and some people now say more than about 60 million people that could be infected with Delta. And so the test with Delta anti-HDV antibody would be important. So I want to thank all the organizers, thank Massimo, and I acknowledge especially Caroline Scholtes and Caroline Shah on the INSERM and on the Virology House Hospital that are helping for this presentation. And I thank you for your attention.
I can start. So it's great to meet you together again this year. Today, I propose to present our current understanding of mother-to-child transmission of hepatitis B and its prevention, and then review the questions that we need to answer to help reach the 2030 goals. These are my disclosures. So what do we know about mother-to-child transmission and TCT of HBV, hepatitis B virus? HBV is transmitted through body fluids, but very likely not through breastfeeding. The main source of infection is perinatal transmission today in the world. And TCT is possible in utero, during delivery, and after delivery, during early infancy, and later if a child is not vaccinated. But perinatal transmission includes TCT, but also other modes of transmission. Immediately after birth, a newborn may be exposed to a person infected with HBV, and this is not only the mother. And the chance to meet someone with HBV is obviously higher in high prevalence countries. In these countries, sexual transmission is not the most important mode of transmission. High maternal viral load is the main risk factor. Difficulty to advance my slides. Yeah. So usually high maternal viral load is associated with HBe antigen, and this indicates a high risk of transmission to the baby. But also, HBe antigen is transmitted to the fetus and may facilitate infection. There are mutants that can escape antibodies or immune globulin, the same. It is possible that using immune globulin in people with high viral load could select mutants. So it's probably unsafe to give immune globulin to mothers with high viral loads during pregnancy. And this was done in the past. In terms of prevention, we have several tools. We have the hepatitis B vaccine. It protects against HBV infection for a long time. And as I explained before, it should start at birth when starts exposure to HBV. We have also the immune globulin, HBig. They can prevent early infancy infection before vaccine confers protection. It is effective and cost-effective in infants born to mothers at high risk of transmission, but it's not available everywhere. Escape mutants may be transmitted despite these two tools, vaccine and HBig. And we need to remember that vaccine and immune globulin do not prevent all infant infections. Studies have reported 2 to 12% transmission when the mother has high viral load. Actually, the combination of immune globulin plus vaccine, starting both at birth, is more efficacious than any of the two. But again, not for all transmission. And also, immune globulin is not available everywhere for cost and logistical reasons. So, in the absence of HBig, there is still significant transmission, which is not prevented by the vaccine, even if the vaccine is administered on time and and the vaccine is efficient. So studies have shown that infant vaccination would be insufficient to reach the 0.1% HBs antigen prevalence goal in children by 2030. So this was the main reason for WHO to update its recommendations last year. The idea is that maternal antiviral prophylaxis can, in addition to vaccine, help decrease transmission. It does not assume that it is as efficient as the combination of maternal TDF prophylaxis plus infant HB plus vaccine. So obviously we need to see how these things cost, and you have here a list of costs that I'll let you read. My slides are not going on. Okay, so how does it, can we organize this antiviral prophylaxis, which is mostly done with TDF for several reasons, but I will not go into the details. So mothers with high risk of MTCT can take tenofovir disoproxil fumarate from 28 weeks. This inhibits viral replication, the viral load decreases. At time of delivery, the exposure of the newborn is lower, and the risk of transmission at this time is lower. And if the mother continues to take antivirals after delivery, for example, for 2 months, it is unlikely that she can transmit HBV to the infant. During this time, it's possible to immunize the infant with the vaccine. However, the infant may acquire the virus if exposed to other infected persons. So there are several questions that are still unanswered, and I will propose a short list of this question. So the first question is really a big question. The first question is about the efficacy of maternal antivirals plus HBig plus vaccine versus HBig plus vaccine without antivirals. So although the update of WHO guidelines is not always clear regarding this point, this update does not assume that vaccine plus antivirals is as efficacious as antivirals plus HBig plus vaccine. There is a related but different question that is also of importance. I would like to go to the previous slide. It's whether we can replace immune globulin with antivirals. This is the question we are trying to clarify, to answer in a clinical trial in Thailand and in Laos. There is another question about whether there is a need to start earlier than 28 weeks. But I have problems with the slides. 28 weeks is the time at which WHO recommends starting. There is also a question about when to stop, at delivery or later. This requires more studies. Another question is about the adherence, because obviously, if TDF is not taken by the mother, there is a risk of transmission. So there is some kind of switch of responsibilities between the professional healthcare workers that are administering HBig to the newborn and the TDF adherence, which is the responsibility of the mother. And we know that self-reports regarding adherence are not always reliable. So we need new ways and affordable ways to measure HBV DNA load, but also tenofovir concentration in plasma or urine. The questions of using antivirals in infants has been debated, but I am not aware of any clinical studies. There are probably some risk at time we stop antivirals, but it has not been really observed in women, in infants who were born from hepatitis HIV infected mothers and also infected with HBV. Next slide. Is there a need for TAF? It comes to the mind of everybody. It's better tolerated, maybe. It's the pharmacokinetics are better, but it's not clear whether there is a definite advantage over TDF. Finally, with the new recommendation of WHO, we need to see what are the problems. We need to understand what are the failures and why. And these will probably help improve these guidelines. These are my acknowledgements. And I would like to thank you for your attention.
Thank you to you, Dr. Jourdain, for this exhaustive review of the perinatal prevention of perinatal transmission of Hep B, which is in fact the pillar of the strategies of hepatitis B prevention on a global basis. And now we can integrate your data with the presentation by Dr. Olivier Segeral from ANR's Emergent Infectious Diseases in Paris, who will talk about free immunoglobulin alternative strategy to prevent hepatitis B mother to child transmission in Cambodia and the result of the ANRS PROHM study. Dr. Segeral, the floor is yours.
Thank you very much, and thank you for the introduction, and thanks to the organizer to give me the opportunity to present the result of the INRS TA PROHM study, which aimed to evaluate an immunoglobulin-free strategy to prevent HBV mother-to-child transmission in Cambodia. Sorry. In Cambodia, the prevalence of HBs antigen among pregnant women was estimated to be 4.4%, and the prevalence of HBs antigen among children aged 5 years old was estimated to be 0.56%. The global vaccine coverage is close to 90%, but was estimated to be only 45% for timely birth dose coverage. In order to design a comprehensive package of intervention that could be used immediately at the end of the study, the principal objective of the TA PROHM study was to evaluate the effectiveness of an alternative strategy to prevent HBV mother-to-child transmission based on, first, the use of HBs and HBe antigen rapid test algorithm to screen pregnant women and to decide tenofovir prophylaxis, a tenofovir treatment for HBe antigen positive women and HBe antigen negative women with HLT more than 40 from 24 weeks of pregnancy, but including also an immediate treatment for those screened later, and an early vaccination for all infants at birth in delivery room within the first 2 hours of life. The primary endpoint was the proportion of active infection in infants at 6 months of life, estimated by plasmatic HBs antigen positivity and confirmed by HBV DNA. The secondary objectives were to evaluate the HBV transmission rate according to tenofovir duration, the HBV transmission rate for non-tenofovir treated women, the safety in mother and infant, and to evaluate the liver disease and tenofovir indication in postpartum for mother, but the result of this last objective will not be presented today. The TA PROHM study is a multicenter interventional non-randomized prospective study. Women were screened by HBs antigen in 7 health centers and 5 maternities. And in case of positivity, they were included in one of the 5 maternities. Tenofovir-treated women were followed monthly until delivery. At delivery, obstetrical outcomes were recorded and infants received the early vaccine. Then the vaccine schedule followed the national recommendation at week 6, week 10, and week 14. Immunoglobulin were not provided and not funded by the study, but could be done if accessible, and it was the case in one of the 5 maternities. At 6 weeks postpartum, women were evaluated for liver disease, and an external committee decided about the necessity to continue or to stop tenofovir. And the last study visit occurred at 6 months, where infants were evaluated by HBs antigen by ELISA. This is the flowchart of the study. From October 2017 to October 2020, more than 21,000 pregnant women were screened for HBs antigen. 1,194 were included in the study, and among these women, 28% were eligible for tenofovir and 72% were not eligible for tenofovir. The proportion of eligible women starting tenofovir was 94%. The proportion of infants and women lost to follow-up ranged from 5 to 7% for tenofovir eligible group and 10 to 13% for non-tenofovir eligible group. And finally, 317 infants in the tenofovir group and 712 infants in the non-tenofovir group were evaluated for the primary endpoint. At inclusion, tenofovir eligible women were significantly younger, significantly less aware of the HBV status. 75% of these women were eligible because of positive HBe antigen test, and 25% because of negative HBe antigen test, but ALT more than 40. The median HBV DNA was 8 log for tenofovir eligible women as compared to 2.5 log for non-tenofovir eligible women. And it is important to note that 11% of non-tenofovir eligible women get a high HBV DNA at inclusion. At delivery, the proportion of premature delivery was similar in the 2 groups. 16 to 23% of women get a C-section, and for tenofovir eligible women, 14% of these women were treated less than 4 weeks before delivery, and 3% of these women never started the treatment. For infants, the measurements were similar in the 2 groups. 13 to 16% of infants receive immunoglobulin all in the same hospital. More than 85% of infants receive the vaccine within the first 2 hours after birth, and more than 95% within the first 24 hours after birth. This is the primary endpoint of the study. Overall, the HBV transmission rate was 1.26% for tenofovir eligible women, 6.5% for those treated less than 4 weeks, and 0% for those treated more than 4 weeks. For non-tenofovir eligible women, the transmission rate was close to 1%. In the subgroup of infants not receiving immunoglobulin, majority of the infants, the HBV transmission rate was 1.5% overall, 8% for women treated less than 4 weeks, but 0% again for women treated more than 4 weeks before delivery. And the HBV transmission rate was also close to 1% for non-tenofovir eligible women. In total, 11 infants were HBV infected in the study, 4 in the tenofovir group and 7 in the non-tenofovir group. In tenofovir eligible women, all these women get a very high maternal HBV DNA at inclusion and with a low tenofovir duration, one refusing to take the treatment. In tenofovir eligible women, all these women were negative for HBe antigen with an ALT below 40, but the maternal HBV DNA at inclusion was above 5.3 log for all. For the secondary endpoint of the study, it is important to note that 50% of women treated less than 4 weeks get a HBV DNA below 5.3 log at delivery, as compared to 90% of those treated more than 4 weeks. The proportion of serious adverse events was higher in the tenofovir eligible group as compared to the non-tenofovir eligible group, and mainly related to liver cytolysis. And 5% of women get a flare after tenofovir cessation. And for infants, the proportion of serious adverse events was similar in the two groups. So, in our knowledge, this is the first large study evaluated an immunoglobulin-free strategy using tenofovir prophylaxis. In absence of immunoglobulin, the transmission rate was 0% if tenofovir duration is more than 4 weeks before delivery. This result is similar to what is reported in randomized control trial using immunoglobulin, where the transmission rate was 0% in per protocol analysis when tenofovir was started between 28 and 32 weeks of pregnancy. However, the HBV transmission rate remains high when tenofovir duration is less than 4 weeks, and this result highlights the importance of an early HBV screening during pregnancy. In tenofovir ineligible women, the HBV transmission rate was 1%. All these women who have transmitted the virus get a high HBV DNA at inclusion, so the benefit of point-of-care viral load implementation could be discussed, but taking into account the logistic consideration as compared to the possibility to scale up immediately the TA PROHM algorithm in all referral hospital laboratories. And another important result is the high time liver dose coverage in delivery room. This is a simple medical procedure which could be integrated into the standard of care of all infants at birth in order to provide an early post-exposure prophylaxis and to avoid missed opportunities. So in conclusion, an immunoglobulin-free strategy with maternal use of tenofovir based on HBe antigen rapid test ALT algorithm associated to an early vaccination at birth could be effective to prevent mother-to-child transmission if the treatment is initiated more than 4 weeks before delivery. By using a therapeutic algorithm accessible in district hospital, this strategy could be used at the district level where the majority of pregnant women are followed in Cambodia, but also in other low and middle income countries. And this result needs to be complemented by an implementation research to evaluate the efficiency of such a strategy in rural areas. I would like to thank the woman and their family, the Methodology and Data Management Center, the physician, member of the committee, the sponsor ANRS, and a special thanks to the clinical research group of Pasteur Institute in Cambodia. Thank you very much.
Thank you to you, Dr. Segeral, for this very, very, very interesting and convincing presentation outlining the cost benefit of adding NUC in the strategy of maternal to infant prevention of Hep B in this hyperendemic area like Cambodia. Last but definitely not the least, Professor Christian Trépo to highlight on the issues relating to the cure of hepatitis B. Professor Trépo needs no introduction and currently is associate with the Lyon University in France. I worked at the INSERM Center for Research in Cancer in Lyon. Christian?
Massimo, dear colleagues, can we cure HBV? How and when? This is a million patients question and $1 billion one. Okay, if I can have a slide. Here on the map, you have a distribution of 250 million chronic carriers, and you can see they are mainly in Africa and in Asia. On the map below, you have liver cancer, and you can see that it almost superimposed. and it is responsible for almost 1 million deaths a year, and it is the fastest growing cancer. On the right, you have a natural history of hepatitis. And of course, we are familiar with progression to chronic cirrhosis and liver cancer. But on the very right, you see this arrow, which is the rescue by Mother Nature. And indeed, Mother Nature can cure HBV. So we have to get inspired to mimic and duplicate this cure. Now, this is the natural history of hepatitis under the actual therapy with nucleoside analogs. This virus suppression is decreasing the incidence of complication and cancer, but doesn't eliminate it. And in fact, it's not surprising because only 10% of HBS is lost after 5 years of therapy. And I remind you that therapy has to be lifelong. Here we are at the picture of what we achieve. Therapy provides inhibition of HBV DNA, and it is a partial cure. What we want is functional cure. Functional cure will be obtained when we clear HBsAg and possibly seroconvert to anti-HBs. On this map, you have a complexity of the liver with different cells, and it reminds us the barriers to functional cure of HBV. The main one is the persistence of cccDNA, long half-life, continuous replenishment, which is not stopped by the nukes and interferon. So this creates an overload of HBs that is paralysis of all immunity efforts. And this is better shown on the left when you see that defective immune response, specific CD8 and B cells are inhibited. We have many emerging treatments, and many more will come to target HBV. So let's start with a few. The first one is entry inhibitor, Mircludex, Belvivirtide. Then we have the NAbs, we'll come back, that blocks the excretion of HBs. The polymerase inhibitors, the nukes, are very familiar to you. And we have also the new one, capsid inhibitors that are effective. And in yellow, you have the siRNA that blocks HBs translation. And you have similar other drugs doing that. And I leave for future targeting HBx or directly cccDNA. But we have also the immune compartment, and innate immunity modulation provide targets, and similarly adaptive immunity with checkpoint inhibitor will be of help too, but this is less advanced. So triple combination therapy is the key to cure HBV infection. We have seen replication inhibitors. We focus a little bit on antigen reduction because, as I've said several times already, this is the key and limiting factor for the moment. And then for the future, we will have many sides of immune stimulation. Now let's start with a combination of drugs on a replication of B. Here we have added nuke and CAM together. And you can see on the left panel that it decreased significantly. It's a synergistic combination. And after we stopped therapy, the outcome depends on initial viral load. If you were low virus load, virus remain inhibited. But on the right, if you have high viral load, then a relapse happens and you should retreat the patient. And this is true for E and plus and E minus. Here we come to one more. We add siRNA to the combination of nuke and CAM. And as you can see, this siRNA is given by injection. You see the arrows there. And after the second shot, all patients achieved robust reduction in HBs, HBV DNA, and even RNA of HBV. All patients that achieved a more than 1 log HBs reduction. And this again is true for E and anti-E. Now, let's look a little bit at immune modulation, which is combined. We start with NUC, TDF, then we add NAP for 48 weeks, then we add PEG interferon. NAP is a strong component. As you can see, it will eliminate serum HBs via intracellular degradation of HBs and inhibition of release of HBs. Let's look at this combination here. At the top, you have a protocol, middle, you have HBs titers, and low, you have transaminase. You can see that when you give TDF alone, HBs is untouched. As soon as you add NAP, you can see that the HBs drop in green to very low level. And parallel to that, you have ALT flares. So together, we see that after therapy, 60% have lost HBs, and this is maintained during follow-up. Conversely, for anti-HBs, it's the opposite. End of treatment, 60% anti-S, then it remains until 1 year follow-up without treatment. So altogether, dramatic durable drop of HBs is obtained. Functional cure is achieved in 35% and remains during 1 year follow-up. And self-resolved flares coincide with HBs. So finally, we started from partial cure, HBV DNA inhibition, to reach functional cure, thanks to antigen reduction and immune response stimulation. And this functional cure is the proof of concept that HBV cure is feasible. And indeed, it is feasible. And whether it will come in 5 or 10 years remains to be seen, but it will be triggered by drug discovery, fueled by antivirals and immunotherapy, and boosted by clinical development, new biomarker, and finally the top of cure. Thank you very much for your attention.
Thank you very much for this important review about cure of hepatitis B. Christian, and now we move to collect questions from the floor. If there isn't any coming in, I will start immediately asking something that Professor Rizzetto discovered of hepatitis delta. And I like to remind that Professor Trépo has been rather instrumental in the discovery of delta as well. Christian, as a stressor quite recently. In other words, that we have a poor perception of the real epidemiology of hepatitis delta because in most regions, hyperendemic for hepatitis B actually, our colleagues fail to target the right population for screening for delta. If you do not screen patients with liver disease, particularly those with significant liver disease, you won't be able to identify delta. So my question goes to everyone, because delta has been touched almost by everyone. And we'll start with Professor Paul Dény, what is his feeling about this, and then ask to the other speakers whether in the region they were concerned, at least Cambodia and others, delta has been properly addressed by targeting the right population. Professor Dény?
Maybe I didn't well understand the question. You mean when do we need to screen for delta?
Exactly, because epidemiology data are faulty because they include a number of studies that have been carried out on blood donors that by definition cannot have Delta because they are liver disease free.
Mm. Yes, it's interesting to see that there is a difference in prevalence when you look for the general population and when you look for the HBs positive patient. And for each country, it's a very 1 or 1.5 log more person that are infected with Delta when you screen the patient that are already HBs antigen positive. That means that most of Delta infection on Earth are probably linked to chronic infection. Acute infection, you may have seen it, but it's very narrow, and the risk of being chronically infected with Delta when you get both virus, that means a co-infection with the B and the Delta, is lower than when we are already chronically infected with the B and you are super infected with the Delta. So for my opinion, I would say that each patient once of its life that has been infected with the B and as an HBs antigen, as an HBs antigen positive might be screened once with a detection of antibody to Delta. And if positive, you have to manage the treatment by knowing this fact that this is complicated to treat for the chronic hepatitis. I would lay it like that.
Okay, thank you.
Patient, once a time, and if there is a flare that is unexplained for an hepatitis chronic B, also if you have a low level of HBV DNR and a high level of transaminase, you must very think of Delta. And the other point is that some part of the world are very endemic for Delta. So you have to know that, for example, in Mongolia, in Uzbekistan, in southeast of Turkey, there is some place which are very endemic. So you have to be careful. But I would say that each patient, there is a lack of information for Delta. So please screen Delta.
Oh, thank you very much for your message. And in fact, we all are puzzled with the epidemiological data coming from the neighborhoods of countries, neighborhood countries to Mongolia and Pakistan. Mongolia and Pakistan are hyper-endemic for Delta in terms of mortality. And interestingly enough, China and India do not report high rates of Delta among their carriers. And the simple reason is that they screen donors, blood donors, rather than patients with significant liver disease. As you say, it's a matter to select the proper target to look for Delta. The comments from the other speakers? Yeah.
Yes, I have some comments here because in the Western Pacific region, we are working with a lot of partners to try to understand the epidemiology of B, C, and D. And as you say rightly, Mongolia has a very high coverage, up to 50% of their hepatitis B patients are infected with hepatitis D. And we also see that also small proportion in pregnant women that carry both B and D. And we wonder how mother transmission is actually going to happen. And these studies are also ongoing now in Mongolia. But what is we are finding increasingly in the region of the Pacific is that we have some Pacific Island countries that are very high in hepatitis D. Kiribati, for example, has 60% anti-HDV positive and 40% viremia for hepatitis Delta. I believe that, Paul, you're working with our collaborating center on looking into the French-speaking Polynesia and New Caledonia, perhaps. But we are starting to see that also and working with other islands like Samoa and Nauru, that also reports 50% hepatitis Delta co-infection. And on top of that, with the whole region of the Pacific Islands where liver health is quite important, we have fatty liver from very high NCD, obesity, hypertension, diabetes is extremely high in that region. So that confluence of risk factors and its impact is not very well known.
Thank you. Let me also bring up another question. In Italy, in 1991, we start a campaign of mass vaccination of newborns and in parallel of adolescents. And as a result of this, we got rid of fulminant hepatitis delta in the juvenile population being exposed to sexual risk or to drug use. Do you think that in hyper-endemic areas of the southern East Asia or Far East, a parallel vaccination program for adolescents is worth to be done, is possible to be done, or there are constraints? Did you get my question?
Maybe I can give part of an answer. We are running a program where we propose free diagnosis for HIV, but also viral hepatitis. And actually, it's very clear that those who were born after the beginning of the implementation of the national program of universal immunization have a very, very low prevalence of HBV. So it seems very efficient. The problem of catching up for those who have not been vaccinated is very complicated to organize. I'm not sure it's very cost effective. And this is probably the reason why the Minister of Public Health is not very committed to look at that.
Oh, thank you so much. Well, I understand that there are no more questions coming through, and we are eager to hear the next session that will be led by Professor Po-Lin Chan, and the next session is in fact on how can reach the 2030 hepatitis C eradication goal. So the floor and the moderation is yours, Professor Po-Lin Chan. And I'd like to thank you everyone again for inviting me. Very kind of you. Thank you.
Thank you, Massimo, and thank you for great coordination and moderation of the first session. So with pleasure, I would like to jump into session 2 and introduce Dr. Mukta Sharma. Dr. Mukta Sharma is a colleague and a great colleague in the WHO Southeast Asia. She's a social scientist and epidemiologist by training, and she's a regional advisor for TB, HIV, STIs, and hepatitis, covering 11 countries of Southeast Asia and South Asia. She's particularly interested in what it will take to end hepatitis C in the region. So over to you, Dr. Mukta.
Thank you, Po-Lin, for your very warm welcome. And Sabaidi, So Sadai, and Savadika to all colleagues in the Mekong region. If there are colleagues here from Myanmar as well, then Mingla Bar. As you know that we are a region that's been hit very hard by COVID-19. And we are a region that makes up about 26% of the world's population in the 5 Southeast Asian countries and the 6 South Asia countries. And very, very serious lockdowns were implemented. Where I'm based right now in India, a very, very significant lockdown happened. We've had close to 55 million confirmed COVID infections in our region. And if we're thinking about picking up 1 in 10 cases, then we've had over 500 million COVID cases in our region with huge amounts of mortality. I'm sure you've all seen the pictures and heard the stories about what happened in some countries in terms of old staff being diverted to the COVID program, all laboratory facilities being diverted to the COVID program, any molecular testing capacity being diverted to the COVID program, and of course the fact that the healthcare systems really came to a standstill and continue to do so in even countries like Thailand that have traditionally been known to have very good healthcare. So in that context, we dare to talk about hepatitis C elimination because we think it is possible. And shocks like the COVID pandemic will happen. but we need to find a way to move beyond that and to refocus the discussion on elimination of hepatitis C. I know that sometimes people are using the word eradication, but we will, for the sake of consistency, work with elimination as the term, which is what the WHO indicators for both mortality and incidence refer to. So next, please. Or would you like me to control the slides? Yep, okay. So in our region, and I said it's 11 countries, we have just been going through a whole meta-analysis process to look at what the burden of hepatitis C is in our region. And if you look at where the burden is sitting, what's very clear is the vast majority is sitting in low-risk groups. So out of the 14.3 million, 12.58 million infections are sitting in low-risk groups. And out of the 1.65 million, which are sitting in high-risk groups, the two really, really big groups that we need to focus on are people living with HIV, as well as people who inject drugs. In men who have sex with men, we continue to see some hepatitis C. We know that there is injecting of drugs, as well as in prisoners. We are seeing continued injection of drugs, and people on maintenance hemodialysis. So these are our key populations where we need to be focusing on for hepatitis C in our region. But the main point is we cannot eliminate hepatitis C in our region by focusing on the key risk groups alone. But they are the low-hanging fruit because there are services already for people living with HIV, services for PWID, for key populations, and we just need to be screening continuously for hepatitis C and making sure that these people are connected to treatment in a test and treat framework. Okay, oops. Now, how do I go back? Let's see. Okay. So we took stock of where we are in our region. And if you think about the 5 key interventions that have been promoted by WHO, universal blood safety and injection safety, harm reduction, testing, as well as treatment, as a region, we seem to be performing particularly badly on the testing aspect. And you can see that there's a lot of progress made on blood safety. There is some progress made on injection safety, although the way this has been measured has changed between the 2 surveys that were done. Harm reduction, we've gone from 27 needles and syringes being provided to each injecting drug user to 157, but our target is 300. But really where we are not doing well, as I said, was in testing. And we have a testing rate in 2019 of 6.9% amongst those who are infected. So we really got the big bottleneck in screening. I'm sure Sonjelle will be saying much more about this later. And for us as a region, the big question is, how do you bring a largely low-risk population into screening? How do we get these 12.5 million people who are not key populations, who are not injectors, who are not living with HIV into testing? And then once they're tested, how do we make sure that these people are on treatment and retained in treatment? Okay, so this is just a visual representation of what I was saying earlier. And one small note on data, this is data which doesn't really pick up the private sector at all. And in our region, if you think of the big countries, 50% of all healthcare is really sitting in the private sector. You look at Indonesia, you look at Myanmar, you look at India. Even though there is a so-called hepatitis program in most countries, the ambition of the Indian hepatitis program last year was to treat 100,000 people over a certain number of people. Out of that, 38,000 were officially reported to have been treated. Another 50,000 were treated in Punjab. But really, if you look at our numbers, about 150,000 are reported as treated. Maybe you double that to take in the private sector into account. We're looking at maybe 300,000 people treated. Now, I was talking about COVID earlier, and as Po-Lin was mentioning, at WHO, we push that hepatitis is seen as an essential service. Hepatitis treatment is seen as an essential service. And these are data from the Pulse survey, which has been conducted by WHO. We're doing rounds of this. There is currently another round going on. But the data which was collected in early 2021, before the really big pandemic hit in 2021 in our region with the Delta variant, was already showing very significant disruption. And if you think about, the key countries where the burden for hepatitis C sits in our region, I'm thinking about India, Indonesia, Myanmar, Thailand. These are the big populations. Then we've seen very significant disruption. Against a global average of 43%, where disruptions have been seen in diagnosis and treatment, in our region, 33% of the countries reported very significant disruption. Now, while all of this is happening, it's very useful to remind ourselves that hepatitis C treatment is not only cost effective, but it's cost saving. And this analysis is something that we did last year, and I wanted to share this with you. Looking at DAAs, either using SOF and DACLA or using SOF and VELPA, what we're finding is that against a lifetime healthcare cost of no treatment at 2,100 USD in our region, I must say this does not include any patient costs. This does not include any opportunity costs. This is just what happens if you do nothing. What is the cost to the system? That's $2,100. But if you treat with SOF and DACLA, then the cost of treatment in our region, an average cost, is $290. If you want to go with VELPA, that's nearly $484. So you can see that the cost reduction, if you do nothing, is more expensive. It's $1,800 more expensive if you do nothing with SOF and DACLA, and $1,600 more expensive than SOF and VELPA. So very simply, it makes sense to treat. We're actually saving money if we treat in our region, and we are gaining almost 4.5 Dalit QALYs in terms of life years saved. The conversation has always been about how expensive hepatitis C drugs are. But in our region, we've really seen a huge reduction in the cost of drugs. Even so, there is wide variation. And I would like to, of course, show you the data from India, where you have VELPA at $90 for 12 weeks and SOF DACLA at $30 for 12 weeks. If you just think about what that means, $30, that is from what the $89,000 figure that sofosbuvir was first sold for in the US. The price of hepatitis C drugs is actually very reasonable in our region. However, we still have countries like Thailand, where despite the voluntary licensing agreement with Gilead, we are paying close to $1,248. Of course, Thailand is seen as an upper middle income country, so the same prices are not applicable as they are in India and other places. But if you think about Myanmar, if you think about Bhutan, if you think about Nepal, these are all low middle income countries. And there are regulatory problems. There are problems in importing, there are problems in procurement that are leading to these increased prices, which are simply not justified, given that the Indian program is able to procure it for $30. Now, adding to this mix is the work that happened with Ravadavir, and this is the trial, the DNDi trial the Storm C1 open label trial, which was conducted in Malaysia and Thailand, which has shown very good efficacy. And we know that Remdesivir is now available with sofosbuvir in a combination of between $300 and $500 for the duration of treatment per person. So we have no excuse. We know that treatment is cost saving and is actually more effective than doing nothing. We know that the drugs are cheap, even though there are clear areas where more work needs to be done and for them to get cheaper than before. So why is it that we are not making progress? And the bottleneck is with the screening. I'm sure that Sonjelle is going to say much more about this, but I wanted to highlight that there are clear opportunities now and innovations in laboratory and diagnostics. The point of care hepatitis C viral load is something which is very exciting. It's a finger prick test put into a single use closed system cartridge, goes into a gene expert machine. You know, in our region, we have something like 14,000 gene expert modules. And because I work on the TB program, I can tell you that in many countries, we have underutilized capacity. But it's just that, oh, this is a gene expert for the TB program. Oh, this is a gene expert for the HIV program, that we're not using existing laboratory capacity for molecular diagnostics. We also have, great developments in terms of the low-cost core antigen RDTs for confirmation of viremia. We are beginning to see lots and lots of studies around that, including stuff that has recently been published in India. We know that DBS now is available for specimen transportation. So instead of taking the machine all the way to the PHC level, to the primary healthcare level, we can also simply transport the systems and send a dry blood spot on blotting paper to a higher level for confirmation of viremia and then treatment. Very importantly, and should be linked very clearly to the HIV testing work, is the self-testing. We are promoting self-testing for COVID. We are promoting self-testing for HIV. I'm not sure why there isn't such a push for hepatitis C self-testing. Making it cheap is going to be really, really critical to that. Using the multi-disease platforms is going to be critical. The work that has been done in Myanmar around that, and this is a map which shows you what are the different platforms in this one particular area. You've got Gene Expert, you've got viral load platforms, you've got ELISA platforms. If we use all of them together, then we have much more diagnostic capacity for Hep C. The other thing to point out is there is a real room for task shifting. We now have clear evidence in our region that when we look at SVR outcomes, whether they've been done by non-specialists or specialists, we are seeing there is no difference. And we have great examples of the C-free study. I think Nicolas must be in the audience. We've seen the great work that was done in Nepal by Sparsha, where very, very good results were attained by community level treatment programs. And that needs to be something we keep pushing for in our region. Oops. Sorry, I'm still trying to get the hang of this. We are now moving towards a regional action plan for ending hepatitis. We want to integrate what is possible to integrate with HIV and hepatitis. We want to clearly separate what is hepatitis specific and needs particular attention. And I want to flag for you what, from a WHO perspective, really needs key attention. The first thing I would say is political commitment. If you think about the fact that there is no declaration, international or in our region, a political declaration which applies to hepatitis. You have several UN high-level committee meetings for HIV, for tuberculosis, for UHC. There is nothing for hepatitis. The community momentum behind hepatitis is not enough at the moment to create that demand that makes policymakers and politicians listen. And unless that changes, we will continue to have conferences like this, where we will keep saying the tools exist, why don't we move? We need to move to the political commitment. Financing is another key issue. Many people in many countries have said, let's go with an integrated program. But then within that integrated program, how do you ensure financing for hepatitis is something that remains to be discussed and looked at. But what is important is, as there is no global fund, and even though there is a so-called hepatitis fund, this money has to come domestically. And the main source of funding often for health in our region is the patient themselves in the private sector. If we can make treatment accessible and cheap, there is appetite even within the private sector for people to fund their own treatment for hepatitis B and C. The second thing which is critical in our region is simplification and decentralization. We are not a region unlike WPRO or Euro, where you have good health services. We are a region where there isn't enough human resources. We are a region where less than 1% of money goes into health in some countries. So taking things down, simplifying it, decentralizing it is really, really important.
Mukta,
the third issue is that, I'm just going to wrap up, Po-Lin. The third issue is stigma. And I know that we talk about stigma in a broad way for hepatitis. But what do we actually do about stigma? How do we measure it? How do we actually put in programs to address stigma? This is an area where a lot of work needs to be done, including by us in WHO. And there are lots of lessons we can learn here from the work that has been done in addressing HIV stigma and TB stigma. Micro-planning cost efficiencies, I think this is something which is clear. WHO has been talking about this. Start small and then go big is how we want to go, rather than trying to go big and then not getting anywhere. Data systems is another problem. Hepatitis data remains very poor. Hepatitis C data is often modeled, and that's fine, except that we don't always have clarity on who needs to be treated where. Local level subnational data is something we're not talking about yet, and we need to get to that. And then finally, the human rights aspects, the equity and sustainability conditions which need to be in place to sustain this program, to take it to elimination, is also something where we need to be working. With that, I'll turn it back to you, Po-Lin, and thank you for your indulgence in allowing me another minute.
Thank you, Mukta, and thank you. That was an excellent presentation. And it's my pleasure to introduce another colleague whom I work very well with and who works with both regions. Sonjelle Shilton is a public health specialist, and she's the hepatitis lead for FIND, the Global Alliance for Diagnostics. So over to you, Sonjelle, for your presentation.
Great. Thank you so very much, Po-Lin, and thank you to the organizers for inviting me, and to all of you for your participation. It seems the slides have disappeared, so I'll keep going until the slides come back. In relation to Mukta's very good point about the screening being critically important to helping us reach hepatitis C elimination, and also considerations of the cost that screening's going to be. If you look at the cost analysis for planning for elimination as a whole, screening is actually going to be the most expensive part at the end of the day. And this is because, as Mukta well said, we need to identify everybody living with hepatitis, not just the key populations which may have specific targeted screening approaches, but the general population, wherein it may be a little bit more diffuse and confusing as to figure out how to screen these people in a cost-effective way. Two examples I can think of is we did a work with the Delhi Health Services, and we did screening at a decentralized level. Anyone who was coming into primary care district hospitals was offered an RDT. Now, when we did that, we found we screened over 40,000 people, and found about 1.9% prevalence rate of hepatitis C antibodies. This is about the prevalence rate in the general population in Delhi, and it cost us around $25 to identify one person with hepatitis C antibodies. Now, in Malaysia, we did a similar program. Now, in the estimated antibody prevalence in the general population there was 1.9% as well. But in Malaysia, we introduced the rapid diagnostic test at the primary healthcare level in a targeted screening approach. So we combined education and information in the primary care saying, look, if you have these potential risk factors, blood transfusion before a certain date, tattoos, piercings, unsafe injections, come to us and we'll screen you. When we did it in that way with a targeted screening approach, we found a prevalence of around 13% antibody prevalence. And so this meant that it cost around $3 to identify one positive patient. So in two situations with very similar approaches using the same technology, a rapid diagnostic test for antibody, by just changing the approach to a targeted screening approach with the combined education, we were able to reduce the cost of finding a positive patient by around $17. So just a quick note I wanted to bring up Mukta's very important point on that. Now to the rest of the presentation. A high-level overview of what our diagnostic landscape looks at the moment. So in 2018 to 2020, we saw the registration of the Sapphire finger stick cartridge, which Mukta has already mentioned. And then the WHO pre-qualification of the gene drive. This is another near point of care molecular technology that can diagnose HCV RNA. And as Mukta has also mentioned, the dried blood spot, the manufacturer protocol for dried blood spot on the Abbott M2000 for HCV RNA has been WHO approved as well as CE marked in Europe. Now, what can we expect this year? Well, another dried blood spot technology, but this time for screening for the hepatitis C antibody that has also been approved using the FujiReBio platform. The AuraSure AuraQuick hepatitis C antibody self-test is coming up soon, as well as the Premier Medical Corp hepatitis C antibody self-test. We know there is dried blood spots manufacturer protocol coming for the Roche platforms, as well as a plasma separation card for hepatitis C RNA for the Roche platforms. And the TrueNATs. This is another near point of care system, which is undergoing WHO pre-Q review now, as well as CE marking, and is currently used in India for hepatitis C HCV RNA. In 2022, we are hopeful to see the Blink-1 platform. This is a point of care platform, which we hope to have a hepatitis C RNA test on, as well as the hepatitis C RNA test for the Samba-2. This is a platform that already exists and is installed mainly in sub-Saharan Africa for HIV viral load and early infant diagnosis. And lastly, and excitingly, we are hoping to see the core antigen RDT in 2023 or beyond. And now this would be a lateral flow test that would be able to confirm viremia. So you could use it without a platform and thus bring it to the lowest level possible, potentially even screening outreach activities. Okay, so as Mukta has mentioned, WHO excitingly has recently made their first ever recommendation on hepatitis C self-testing. This was done in July at IAS, in which WHO recommended that hepatitis C self-testing should be offered as an additional approach. Now, we know that this recommendation was based on a lot of evidence on the feasibility, acceptability, usability, cost effectiveness of hepatitis C self-testing, building on the large evidence base that we have from HIV self-testing. So now what we need to do is understand how hepatitis C self-testing is actually working in the real world. To do this, we've embarked on a series of studies in Pakistan, in Georgia, And I'm going to focus today on the one in Malaysia, as this may be more relevant for you. So in Malaysia, we are integrating hepatitis C self-testing into existing HIV self-testing online platform. And we're looking at testing uptake as the primary objective. It is a randomized controlled trial, and we estimate to enroll 750 participants. And if you're interested, you can look at the study designs of all 3 trials. They're registered on clinicaltrials.gov, and we put the websites there for you. In Malaysia, we are looking at both the oral fluid and the blood-based hepatitis C self-test. We are working with the Ministry of Health Malaysia, Malaysia AIDS Council, Love Foundation, and DNDi. And now these are preliminary results. We started enrolling on the 7th of September, and as of the 14th of November, we see that those participants who were offered the hepatitis C self-test have completed testing 99%. 99% of the participants have reported that they have completed the testing. Whereas those who were referred to their nearest center for screening for hepatitis C in a professional center, 31% have completed treatment. So these results are preliminary, but we are seeing that hepatitis C self-testing may really have a great potential to increase uptake of testing. Now, dried blood spot is also available. Manufacturer protocols are now available. And what DBS will allow is you can take a sample, as Mukta was saying, outside of the clinic. You could take several drops of blood for screening and for confirmation. You bring it to the centralized setting. Those who are negative, you stop testing. Those who are antibody positive, you reflex to viremia testing, and then can get those people on treatment. The idea here is that the patient, it's simplified for the patient, so you have less chance of losing them through the care cascade, as you often see when people have to move from one place to another for each step. This is just some quick results. I've put the poster that we had from EASL last year of our 4-country multi-center evaluation, real-world settings of these manufacturer protocols. And what we can see here is that the Abbott and Roche platforms have very high sensitivity and specificity when using DBS and plasma card separator. Here, this is more for your knowledge later on. These are the available near point of care assays on the market. Just want to point out, we are doing a study with a community group in Manipur using the TrueNat for same-day test and treat. 100% of those who are viremic have been initiated on treatment same day. It's taken from 6 hours to 9 hours and 58 minutes for screening to first pill in the mouth, using TrueNat as a near point of care. These are the upcoming assays I've mentioned. Just quickly note that technology is only as good as the system it is placed in. Point of care doesn't always equal impact, and the most critical aspect is simplifying that patient journey. I have an example here that I'll just quickly run through. In Georgia, a lot of people were being lost between screening and follow and confirmation. So we put a gene expert in 4 places versus reflex sample referral to a centralized location versus standard of care. And what we see is, for both the gene expert and then just taking that blood draw immediately after the RDT, 99.8% of participants received the RNA versus 100% in the gene expert arm. We spent $80,000 to put those gene experts there, and it was a minimal cost outlay for that reflex testing, but we got the same results. So the key takeaways are that hepatitis C self-testing is emerging as a tool that can increase uptake. Dried blood spots have stringent regulatory authority approval, and there are an increased number of point of care RNA platforms available. I would like to thank you very much.
Thank you so much, Sonjelle. That was truly inspirational, because we now have a tool, an additional tool to add to the armament of hepatitis C testing. So I'm going to now very quickly move forward to Dr. Yulet Bai, who's a researcher lecturer at the University Health Sciences in Cambodia, with a background of laboratory diagnostics and biomedical research, and he was trained in France. He was also former director of Foundation Merieux in Cambodia till 2020. Over to you, Dr. Yulet, to speak on the topic of hepatitis B and seroprevalence among public health sector healthcare workers in Cambodia. Over to you.
Thank you, Chair. Good afternoon, ladies and gentlemen. My name is Juliet B. I'm a researcher from the University of Health Sciences. I'm from Cambodia. I'm pleased to present to you my study on entitled Hepatitis B vaccination coverage and Hepatitis B and C seroprevalence among healthcare workers in public sector. This study was conducted in late 2019. In Cambodia, the burden of hepatitis B and C is still hard to be estimated in general population. And even more, there's no data among healthcare workers. However, they are at high risk of getting infection and also of transmitting diseases. So it would be worth to consider to conduct this study in order to consider a national strategy for healthcare workers towards these viral infections. The objective of our studies was, one, to obtain HBV vaccination coverage among healthcare workers in public sector, two, to describe knowledge, attitude, practices, KAP towards viral hepatitis prevention and vaccination, and third, to measure prevalence of HBV and HDV among them. It is a nationally representative cross-sectional study, which is based on two-stage cluster sampling designs. We have selected 26 clusters from 100 operational district OD and 8 national hospitals and H. To reach the target sample size of 761 healthcare workers, 30 of them were randomly selected from each cluster. The KAP was assessed by face-to-face interview on structural questionnaires. Blood collection was also done to test HBV and HCV serology and also for HCV on a viral load. Here are our findings. The table represents the characteristic of a participant. So in total, 755 healthcare workers are sub to participate in the study. So the proportion of 45% of male and 55% of female is similar to the general population of healthcare workers in my country, which accounts currently up to 25,000 in total. 50% of participants have age between 20 to 34 years old, and the majority of participants have profession as nurses, 42%, followed by midwife, 30%. As education, 57% hold bachelor degree and associate degree, which is corresponding to the bachelor held by nurse and midwife. This table shows the frequency distribution of correct response to of knowledge of HBV and HCV on hearing, on transmission and prevention. I would like you to focus only on the yellow highlight. Here you have the column of answer to HBV and the column answer for HCV. As you can see, only 36% know that eating with HBV or HCV infected people will not get them infected. Only 57% know that HBV and HCV cannot be transmitted through sneezing, coughing, and spitting. And very low percentage, 17%, know well the route of transmission from mother to child. Next. We also find low knowledge on HBV vaccinations. As you can see, only 56% know that an adult should receive 3 doses of HBV vaccine to be effective, and only 40% know that a child should receive also 3 doses of HBV vaccination to be effective. Only 37% know that a full dose of hepatitis B vaccine can protect anyone for more than 20 years. We found also low knowledge on diagnosis, treatment, and also available guidelines for treatment hepatitis B and C in the country. Next. This table shows the frequency of response or attitudes towards risk exposure, testing, infected patient, and vaccination. So as you can see, 67% think that to avoid contamination to and from patient, it is important to screen all patients. 67% think that they would accept if they are being asked to take care of infected patients. Only 52% think that HBV and HDV infected patients should be taken care separately from other patients. This would indicate some kind of stigma among healthcare workers toward infected patients that we should consider. 78% think that in protecting someone against HBV vaccine is very effective. So you can see that there's still some healthcare workers who continue to think that HBV vaccine is slightly effective or not effective at all. We found also issue on practice for healthcare workers on prevention and vaccination. Healthcare workers answer that they ever tested for 72% for HBV and 55% for HCV. Here, as you can see, 57% answer that they always recap needle after use in their everyday practices, which is very worrying. Healthcare workers also answer that they ever vaccinated for HBV vaccine for 46%. And the majority of them receive vaccine at private facility. This table shows the prevalence of HBV and HCV. So the prevalence of HBs antigen positive were 4.9%, and acute HBV prevalence were 1.1%. For chronic HBV infection was 3.8%. For prevalence of HCV, HCV exposed or anti-HBV positive, the prevalence was 2.3%, while the active HCV or viremic HCV were 0.9%. We didn't find any co-infections of HBV and HCV among healthcare workers in our study. For HBV prevalence, we found the prevalence similar to other countries in Asia. In Laos, PDR, 5% of HBs antigen among dentists, and Indonesia, 6.2% of HBs antigen among healthcare workers. A recent study in Cameroon in Africa found a higher prevalence of HBs antigen positive. About HBV vaccination coverage among healthcare workers, I would say HBV protection coverage among healthcare workers. This is defined in our study as self-reported of having completed 3 doses of HBV vaccine, or having immunity due to vaccination, or having immunity due to natural infection. So our HBV protection coverage represented here in pink chart, which account for 59%. The univariate analysis found no significant association for HBs antigen positive, but for HCV exposed or HCV HCV positive, we found that the older age group, especially for healthcare workers more than 50 years old, have 9 times more likely to having anti-HCV positive compared to the reference group, the younger group. This last table shows the univariate for HBV immunity or vaccination that I just call that HBV protection coverage. So the data here are all significant statistically are shown only in this table. So as you can see, the younger and the higher education the healthcare workers are, the more they get vaccinated. We can see that nurses are less likely to get vaccinated or to get immunity compared to doctors as profession. We can see that healthcare workers who know that HBV vaccine can can prevent infection are 2 times more likely to get immunity or to get vaccinated. Healthcare workers who ever tested for HBV are 7 times more likely to get immunity or to get vaccinated. So in conclusion, our findings show an overall low knowledge on transmission, prevention, and treatment of HBV and HDV among healthcare workers in public sector. A particular low knowledge on vaccine protection effectiveness and dose of vaccine, and this includes midwives, nurses, and doctors who them are at the front line of providing vaccine to a patient, which is critical because it will be difficult to persuade a patient to get vaccines. We found also some indication of stigma and discrimination among healthcare setting. A large majority of healthcare workers receive vaccination at private facilities. This might due to a national vaccination program provide only HBV vaccine only for children. There was a high demand and uptake for testing among healthcare workers, but those who are not yet vaccinated or not have immunity are less likely to have been tested. So at the end, there is a real need for a national policy for healthcare workers, including testing, vaccination, care, and treatment, and a strong policy on stigma discrimination toward infected patients. This is my research team led by Professor Sapon Motana, the PI of this project, and other colleagues. And thank for all participants and especially for partners, including the WHO Fondation Merieux. Thank you for your attention.
Thank you, Dr. Yuret. That is really interesting and really significant because this is one of the first studies in this region that really goes and looks into healthcare workers as an at-risk group. So I'm going to move on to Ms. Philawang Sipulang, and over to you, Philawang. And Ms. Philawang is the researcher at the Central Merieux Labs in the Vientiane. She's a research assistant responsible for routine hepatitis activities in Lao Christophe Merieux, and is also a graduating PhD student enrolled in the University du Laos 3 Paul Sabatier, studying hepatitis B and hepatocellular carcinoma in Laos. So this project that she's going to present is a collaboration between Laos, IRD, and Institut Pasteur Paris. So over to you.
Well, thank you very much, Po-Lin. Hello. Can you hear me? Okay. Thank you very much, Po-Lin, and good morning and good afternoon, everyone. So I will present you our preliminary result of our study on a relationship between the evolution. Sorry, I cannot control the slide presentation.
Maybe double click first. Try double clicking.
Okay. No. Voilà.
There is a bit of delay. Yes, you can page down and page up.
Yes, and so viral hepatitis is one of the major public health concerns around the world. In 2019, WHO estimated that around 300 million people were living with chronic hepatitis B infection, with 1.5 million new infections each year. Hepatitis B result is an estimated around 8,000 deaths, 8,000 million. 8,000 deaths, mostly from cirrhosis and hepatocellular carcinoma. Laos is the landlocked country with 7.2 million population. Around 8% of Lao population are living with hepatitis B. Estimate number of 5 years prevalence of liver cancer is around 19% of all cancers. Laos is the third highest incidence for liver cancer after Mongolia and Egypt. In our country, like we saw in the Po-Lin presentation, our data is always blank, and we still lack of current accurate data on hepatitis and on liver cancer in the country. So next, I will talk about the Center for Infectious Diseases of Manila, where I work and where we collect the samples. Our center was funded by Foundation Manila, opened in 2009, and hand over gift to the Ministry of Health Lao PDR. Our center serves viral load tests for hepatitis B and hepatitis C since 2010. And until now, we have around 8,000 hepatitis B patients diagnosed in Lao public or private healthcare facility and came to our center for diagnosis, confirmations, and follow-up. Among them, less than 20% access to good treatment and good follow-up. So our main research question is, can we identify predictors of the evolution toward liver carcinogenesis in hepatitis B infected patients? To respond to our main research questions, we conduct a retrospective and prospective cohort study of hepatitis B infected patients followed at our center from 2010 to 2020 with inclusion criteria below. Hepatitis B diagnosis and still follow-up at our center, aged more than 14 years. They have the first viral load detectable and aminotransferase as first sampling. The naive for antiviral at first viral load. Before data collection, we explain about the study procedure to each patient and ask for signed and informed consent and interview through questionnaire. Sorry. After that, sample collection and abdominal ultrasound were performed by specialists. Some of blood samples were immediately tested for CDC, aminotransferase, and alpha-fetoprotein, and some were stocked in our biobank for other tests. Next. We use the COBOL software and FileMaker for data entry, and we use the Stata for data analysis. There were 126 patients included in our study. In collaborate with medical team, we explain the laboratory test result to patients and send patients to expert if necessary to start for treatment. The median age of participants were around 50. Median age of suspect group were higher than normal group, and 65% of them were male, and 92% of suspect group also were male. In the majority of them has a quite high education and had a good income. To classify in suspect to cirrhosis or HCC group, we based on that we can do in our country, like APRI-score or echography. Only 16% had smoked, but they cannot stop for drinking. There were around 54% still drinking a lot because it's the lifestyle. And 47 of them eat some time of the office. By questionnaire, there were 71 people who had tested for opisthosis by stool examination, and among them, 39% had positive result of opistokis. So 59% of patients received antiviral treatment. Among them, 75% were compliant, 21% initial treatment 2-3 times, but stopped on their own, and 2.7% initial treatment more than 3 times. In suspect group, there were no different ALAT and ASAT between initial and the last one. In contrast, the last viral load is decreased compared to initial one. For the next step, we will continue to perform the laboratory testing for hepatitis B genotyping, subtyping, and phylogeny, and the PCR Doppler digital to detect the circulation of mutation on free circulation DNA and to detect the circulation of opistokit virinae DNA at Institut Pasteur Paris. And that's all for me. Thank you very much for your attention.
Thank you, Philowath. So I will remind the participants that we're slightly running over time and will extend the symposium by around 10 minutes or so. So we will now start with about 5 minutes of Q&A. And to kick off, Philowath, from your last presentation, there seems to be some amount of interruption of treatment when you say people stop and start. Is that true?
Yes, they stop by themselves and they start again with doctor, and after that they stop by themselves.
What might be the reasons for this, and is there an attempt to track them back and see what's going to happen to them?
The duration that they stop is always they didn't understand well how to take medicine. And some patients said they're lazy to take it because it's the same, it's not better, and sometimes it's stopped by doctor. Yes.
Before they finish the treatment.
Yes, and they come back again because they have some symptom, or yes, they have the same symptom, and then they retest for viral load, and it's high viral load, and they have the high aminotransferase. Like this, they must start again.
So I'm just going to move on to maybe a related region. Mukta, you said that WPRO was different. Actually, it's probably not as different. And the same barriers and bottlenecks are happening in all countries, and some countries are a little bit better. But as you said, when you look at the micro data, if we have micro data or granular data, we start to see a lot of holes in the response and in health systems. Now, going back to your region, you mentioned that there's a lot of key bottlenecks. Is there one priority area that you think must be done so that we can accelerate in the next 9 years to 2030?
I think there's only one priority for me now, and this is the lesson I've learned from TB. TB was the biggest infectious disease killer, continues to be the biggest single infectious disease killer in the world. The drugs were available. You can treat TB for $15 in India. And yet we see a case fatality rate of 17%. And what I've learned from TB is, unless there is really serious political commitment, unless you take a disease out of its biomedical box, you're not going to see the real drive to move things. We very clearly need money for hepatitis. We very clearly need political commitment. and we need demand generation. So for me, those are the three priorities, which I would put at the top, followed very, very closely by decentralizing screening and testing. Back to you, Po-Lin. A short answer to a complicated question.
I think it's very good, but hold that thought. So before we go to that, hold that thought, I'm going to ask Dr. Hewlett, because your study is astounding, because this is the first time we see direct evidence of hepatitis B and C in healthcare workers themselves. And as you mentioned in one of your last slides for conclusion, you said that one of the reasons why healthcare workers get vaccinated privately is by themselves and out of pocket is because the national immunization program doesn't include adults.
Yes, of course.
Do you think that we can move this forward, the discussions in Cambodia, but also many, even in Mukta, in your region, it's probably the same, because immunization programs have traditionally focused on children, but because of COVID-19, they morphed into adults.
Yeah, so as you already explained that healthcare workers in Cambodia go to find access to the vaccine by their own pocket. And they also know very well about, they should know, I could not say very well because from our finding it's not very so well. They know that HBV vaccine can prevent them. So they seek to find vaccine by paying themselves. Otherwise, in public facility, only children that can have access free in the national immunization program. So after this, I think in terms of national policy, we should seek to find, to provide public vaccine HBV in public sector that would have to increase the vaccination coverage that I mentioned, or vaccination or HBV protection coverage in the long term as the WHO plan to reach the target very soon. Over.
Mukta?
I was just going to say, Po-Lin, that for the whole issue of adult vaccination, yes, I mean, typically who do you vaccinate? You vaccinate very young kids. Maybe in the Western countries, you vaccinate young people when they're going to university for meningitis or something, or you vaccinate people who are older for flu. That there is no real program that reaches out to young adults or to adolescents generally. And in our region, I think there are two big problems. The first is that the Global Fund or Gavi will not pay for vaccines. That's the first financing problem. And this is not picked up by either of the two really, really big donors in our region. And the second issue is just that we've not really managed to get consensus and agreement on simplifying vaccination for adults. We still have this problem where people are saying, well, you must test first to see, in countries like Myanmar, where there's such high prevalence, whether they are in fact already immune. Then by the time, you get to that, you've lost half the people. Then you do the first, the dosing schedule is something people haven't agreed on. And then people are still saying at the end of 1 year, you must assess to see whether antibodies have been formed. So when it's not like a one-shot thing and say, okay, we vaccinated you, now go. And we need to be able to simplify that and have very clear guidance for member states to say, why is it important for you to invest in this? We've not made the investment case for this at the moment. That's the bottom line. The investment case for vaccines amongst kids, yes, but for adults, for adolescents, that's not been done, and that's work we need to do, I think. Back to you, Po-Lin.
Thank you. That brings also about the investment case for hepatitis C self-testing, Sonjelle. Do you think that hepatitis C self-testing can approach under $1? Because apparently in a recent announcement by the Clinton Health Initiative, CHAI, they have now negotiated one of the WHO pre-qualified hepatitis C rapid diagnostics to under $1 now. And Egypt buys it for $0.50 even. So the tests are all can go down. So over to you, Sonjelle, for maybe a very quick response, and then we'll pass it on to Gonzague.
Yes, excellent. So that's a great question. There's a few things that need to happen to be able to reduce the price on the hepatitis C self-test. One of the things we need to do is increase the volumes, right? So this is why Egypt was able to get the professional use RDC so inexpensively, is because they had huge volumes. And so we need to grow that demand for hepatitis C self-testing. We also need to increase the manufacturers that are in the field. Right now, there's only one oral test manufacturer and one blood-based manufacturer. The blood-based manufacturer's professional use test is around $1, a little bit less. So there could be some room for that. The oral manufacturer is going to be tricky, and we're not going to see buy downs like we see in the HIV self-testing space. So we will have to make concerted efforts to grow the market demand and incentivize manufacturers to get into the space.
Thank you very much all. And I would like to thank on behalf of the organizers and everyone, your excellent session 2 speakers. So I'm going to pass it very quickly to Dr. Gonzague. Over to you.
Scientific committee, I would like to thank all colleagues who delivered fantastic presentation, as well as Massimo Colombo and Po-Lin Chan for sharing the sessions. The presentations were very informative, and they contributed to our knowledge of hepatitis B and C and the methods available to fight these epidemics. So we are also very grateful to those who have contributed to the logistical aspects of this webinar. Let's meet next year in Vientiane. Thank you very much to all participants.
The liver is one of the body's principal organs. In fact, the liver is essential for life due to its role. It acts as a filter for the blood. It is involved in the synthesis of the main plasma proteins. It is the main energetic reservoir. We cannot live without a liver. In Greek mythology, Prometheus stole the god's fire. As a punishment, he was condemned to have his own liver eaten every day by an eagle. In response to an aggression, the liver is an organ that can reconstitute itself thanks to a process called regeneration. An acute inflammation of the liver, or acute hepatitis, can lead to recovery, death in the case of fulminant hepatitis, and in a third more common case, to chronic hepatitis. During the chronic process of cell regeneration, a mechanism called fibrogenesis might occur, leading to liver damage that causes cirrhosis and eventually cancer. Today, 5 major viruses are associated with viral hepatitis: A, B, C, D, and E. 2 of them, HAV and HEV, are associated only with acute hepatitis. 3 of them, HBV, HBV plus HDV, and HCV, in addition to acute hepatitis, can lead to chronic infection. The hepatitis viruses can be transmitted by different routes depending on the virus. Both the hepatitis A virus and the hepatitis E virus, which are resistant viruses in the environment, can be transmitted by hydric contamination or through the fecal-oral route. In contrast, HBV, HCV, and HDV will be transmitted parenterally, such as blood contamination for B, C, and D, and sexual transmission for B and D. A specific HBV transmission of the disease is the mother-to-neonate transmission route. The hepatitis A virus is responsible for acute benign hepatitis in 1.4 million cases per year, which never go to chronicity, and most clinical forms remain asymptomatic. Vaccination is efficient and useful for travellers. The HEV burden is estimated at 20 million individuals per year. It is an acute hepatitis, sometimes severe, especially in pregnant women during the third trimester of pregnancy, leading to fulminant hepatitis and death. A vaccine against HEV has only been approved in China. Globally, approximately 257 million people have a chronic infection due to hepatitis B, mostly in certain areas, Asia, West Pacific countries, Sub-Saharan Africa, and certain specific countries such as Mongolia. There are approximately 800,000 deaths due to HBV per year every year. The chronicity is linked to the persistence of the viral genome in the liver cells. A therapy by inhibition of viral replication is efficient, but cannot eradicate this persistent viral DNA that may also be integrated in the host genome. Therefore, there is a lasting risk of hepatocellular carcinoma. A very efficient vaccination schedule may eradicate the transmission of B and B+D. It is part of the WHO hepatitis eradication goal for 2030. HDV is a satellite infection for hepatitis B infected patients in humans. 15 to 20 million people are infected. It's an uneven epidemiological infection rate with prevalence of over 20% in some countries, Central Asia, Africa. It's the most severe form of chronic hepatitis, increasing the rate of development of liver cirrhosis and cancer, and also fulminant hepatitis. There is no efficient therapy. The HBV vaccine protects a person from HDV co- or superinfection. Globally, approximately 71 million people are infected by HCV. This infection is chronic in a huge number of cases, over 50 to 80%. It may represent a high proportion of individuals at risk of liver cancer in some countries, such as Egypt. During the last 30 years, strong progress has been made with an antiviral therapy. Nobel Prize for Harvey Alter, Michael Houghton and Charles Rice. And a high efficient healing rate is now obtained, with viral eradication in nearly 100% of patients treated for 8 to 12 weeks. The main problem is that only 10% of people are treated due to a lack of viral infection screening and access to treatment, cost, availability. It is part of the WHO hepatitis eradication goal for 2030. During the next decade, the goal of the World Health Organization is to help countries eradicate hepatitis C and to control hepatitis B infections. This will become feasible by knowing the latest viral hepatitis therapeutic approaches, providing access to diagnosis and therapeutics to everybody, high-technicity reference laboratories combined with point-of-care screening tools and drug accessibility will help such goals. Limiting the cost by using generics, continuously promoting vaccination programs for the virus when relevant, hepatitis A, B and D. In the next decade, hepatitis could hopefully follow the path of variola.